Morning. It is Thursday, April 24th, 9:30. Thanks for hanging in with us this morning. And we are continuing our work on S-126. Today, we're going to actually be moving into additional sections around reporting. And also, even though it's not in the current version, it is our understanding that there are budget requests. So we're having JFO back in to update us on possible fiscal appropriations that would need to be in here or go to appropriations.
Right, for the record, Noel Langwell, Joint Fiscal Office. I do have an updated fiscal note, which I did this morning. So really, let me start here. I'll start by kind of bringing you on a little journey of the financial piece of this. When the bill passed the Senate Health and Welfare Committee, or I should say as it was introduced, because it was a committee bill, there was a fiscal note at the time that basically had 5 new positions to the Green Mountain Care Board, 2 limited service positions to AHS, and had a total of 1.88 million to AHS and 1.5 to the Green Mountain Care Board. That was based on estimates that were provided to me by AHS and the Green Mountain Care Board at that time, based on their understanding of the resources that would be needed. Bill goes to the Senate Appropriations Committee. The Senate Appropriations Committee stripped out all the appropriations, that they often do, because there's a sense that the Senate has had a principle in the past of they didn't have the budget bill at the time. Where in the House, they can build in money when there's an H bill, they can build in money in the budget, but they didn't have the budget then, so they pulled it out so they can think about it in context of the whole budget. So the money was stripped out of the bill at the time so they can think about the cost of the bill. Now, whether that becomes a sort of commitment to the bill or whatever, it can be argued. But anyway, fast forward, more information becomes available. Senate Appropriations Committee passed out their appropriations amendment to the budget yesterday. And it includes new numbers. No real a little bit of change to the Green Mountain Care Board, but more change to AHS. And what that stems from, and you'll hear from them later, what that stems from is a reevaluation of what was needed. At the time when they initially provided me with the information, they were thinking it in context of the head model and the overlap with the head model. Further thought from them was like, no, this actually needs to be different. And they reassessed it and they provided new numbers. And so the money that's in the budget now reflects more of their current thinking of what the needs are.
Mari, but can I ask just really quickly, just what was passed out of the Senate yesterday? Does it include the most up-to-date current rationale thinking? Okay.
And I'll go over those numbers.
Okay.
So what was that sentence said yesterday?
Mari has a
I'll get to that.
Okay, thank you. I just.
So you can either hold your question until I show the numbers, unless it's something different.
Yesterday I asked AHS if they would need more money and they said no. I'm confused what happened in the last 12 hours, other than.
They're probably thinking they need more money than, it depends on what their context was. And you should ask them again, was it more money than what they already told me they needed? Or more money than what they're already appropriated?
May I ask, Mari, was that in context to section 10 around the data piece? I think that was,
Yes,
yes.
I asked them.
Yes, they have not requested an appropriation to do that work.
Okay, all right, thank you for that clarification. So the current thinking with AHS, they're the number on the top there. They told me they need $5 million, but it can be over multiple years. So they said they could do half for this fiscal. So this reflects half of the appropriation that they would need. And then obviously they would come in with their budget next year with the other half. So the numbers above, and if you want more specificity about what these needs, I would ask you to hold your question for when they testify. But they need 2.25 for a feasibility analysis and transformation plan. development with hospitals, VAs, primary care organizations, and other community-based providers. They need 125,000 to support development of quality and access measures, targets, and monitoring strategies for a statewide population health plan. And 125,000 to support development of hospital budgets or other alternative payments for Medicaid. Now remember, these are the half, so they really need more than that. They need 4.5, 250 and 250. So that's what they say they need. So they're getting, so the bill of the appropriations that came out of the Senate and what we're saying the need is at the moment is reflective of that. So it'll be 2.5 for AHS. Initially, there was 2 limited service positions that those are gone. And there was some money that was in the HIT fund that's also gone. Green Mountain Care Board, when the bill passed out of the Senate Health and Welfare Committee, had 5 positions. Senate basically pushed back and said, well, if you only got 3, what would that look like? And so that's what this is, because they were looking at it in the context of the budget where there's 6, because there's 3 already in the budget and then 3 here. So that's 6. And so these are the 3 positions, assuming that the Green Mountain Care Board will probably come back and ask for more positions next year, but this is what they're saying they can do the work with this year. Otherwise, their appropriation hadn't really changed. There's 512 for the 3 positions. There's $500,000 for contract work that'll need to be done. And then there's standardization of electronic hospital data submissions. There was a sense by the committee and others that we could use HIT fund for this and save a little bit on the general fund. So what you have here before you is the latest thinking on what the needs would be to implement the bill as proposed. Now, again, if you want more specificity, what does that mean by feasibility analysis or transformation plan? I recommend you ask those questions of the HS when they come, and vice versa the Green Mountain Care Board, which I believe are here this afternoon. So the total appropriation of general fund in the Senate Appropriations Bill at the moment is 3.5 million, 150,000 HIT fund for a total of $3.66 million. So that's the current thinking of what this bill would cost for the Agency of Human Services and Green Mountain Care Board to do this work.
And you don't have to answer this right now, because I know you won't have it off the top of your head. But if we could get the balance in the HIT fund.
I actually can't do that. I had it pulled up yesterday. And then, of course, I closed that window about 14 minutes ago. But if you give me a minute, now you can see all that stuff. You don't want to see that. All right. If you give me a minute, I want to say it was let me pull it up. Talks amongst yourselves. Here we go.
It's a chief fund, is that what it's
Health
called?
Information Technology Fund. So
Special fund.
this is a report that was put out, I believe, in the fall. And it's the spending from the HIT fund as of the end of closeout fiscal year 2024. At that time, there was about $7.4 million on the bottom line. That said, I don't know what is proposed to be spent. When I asked recently by HS what the spend was, they didn't actually have a number for me at the time. But one could argue you have about they have been raising more money than they are spending in the last several years. So
This
at the
comes
moment-
from the claims tax, right?
this comes from the claims tax. It's 0.199% of claims. And the rest, and there's other money that goes to the general fund out of this tax. So currently there's a balance of 7.4 million. Again, I don't know what they plan to spend this year, so what's allocated, obligated, et cetera, but this is how much is in the fund at the moment, or as of the close of 24.
Go ahead, Woody.
Claims tax. Who pays for that? Is it our Blue Cross Blue Shield?
So it's a tax on all health insurance claims.
So couldn't we use that money to help Blue Cross Blue Shield in the long run?
So right now, we have a 0.999% tax on claims. It's almost 1%, but it's 0.99%. 0.199% goes into the HIT fund. The rest, which is about 0.8%, goes into the general fund. So, I believe it raises somewhere in the range of 15 to 20 million, maybe. I don't remember off the top of my head. I could do a whole presentation on it sometime, but not right now. I mean, actually, I could do it right now if you want. I have an issue brief on this I could pull up, and I could totally, if you want to kill some more time. But in short, as the money, this would not be enough to help Blue Cross Blue Shield because there's going to be money that's going to be used already, mostly for Vital and other electronic medical record stuff. Some of it gets matched, some of it is not matched. There's a whole plan around how this money is spent. But if there was a balance, even if you gave 2 or 5 million to Blue Cross Blue Shield, it's not going to help much. The rest of the money is in the general fund. So if you want to take that out of the general fund and do that,
How much is in the general?
well, there's probably going to be another 15 or 16 million off the top of my head, but that's already allocated into other causes. And that would be considered a bailout. So,
That's kind of what we need to do, isn't it?
well, I'm just throwing it out there. You guys are decision makers, not me. But you would have to find, more money to backfill the budget. And a lot of this, well, this used to be used for Medicaid match. Now it goes in the general fund, so it's all fungible, right? So, but in theory, it was used for a Medicaid match, so.
And at least in my opinion, if we were going to do something like this, then we might as well look at the complete restructuring of the healthcare delivery system. We're going to use this kind of money to do what you're talking about.
Not delivery, funding,
Hmm?
funding system.
Fund it.
But we can only use this money for certain things. This is a special fund and it has to be used for certain things.
Yes and no.
Always.
Yes, and you can not
Let's
say.
barricade.
Yes, you can change
I
it.
was just curious as to how much of a balance it has in there.
Now, keep in mind, are you gonna tax them and turn around and give them their own money back? Now, it's also not just Blue Cross Blue Shield, it's every insurer that has claims in the state. Food for thought, happy to come back at another time or work with you one-on-one to explain in more detail what's in the balance if you're ever interested.
Any other changes? Oh, I'm sorry.
Understand.
I'm not saying don't do it, I'm saying.
Any other changes from AHS or Green Mountain Care Board? Everybody, and we will ask each of them as they come in here to kind of give us an in-depth of what do you need this for, and then make decisions from there. Leslie,
So, one of the topics that came up yesterday was an emergency fund, we had medium and long-term presentation, but we didn't have a short-term. So I'm just curious to understand how that might unfold, and no one may know, and I get that, but we only have about a month. So I'm worried on the short term of the sustainability of our system and what it might require. And we don't know, I get it, but how does that unfold here? Do we have any sense of that? No,
I
no, we
don't
got
think
nothing.
that unfolds here. This is just.
This is the current state of.
This is S-126, the work that is being contemplated in S-126, and this is the budget requests that are being asked for the various places that would be doing the work. So it's up for us to determine what we wish to appropriate. Well, it's not up to us, it's actually up to appropriations, but I just wanted Nolan to give us a
I'm just
sense of what is being asked. All right, any other questions for Nolan?
How big?
This is off subject probably. How did they come up with $200 million for helping out Blue Cross Blue Shield?
I would defer to the Green Mountain Care Board, but with a star asterisk that I assume it's based on their analysis of when they're looking at the hospital budgets and looking at the insurers, and they can run these analysis and determine what they think need would be in order to bring down premiums. And also probably working with their actuaries, but you could ask them later today. It's actually a very good question. The last thing I just want to say is I found a typo. So in the middle of the.
One typo in
Yeah,
everything.
well, because of rush, but in the middle of the chart, it says, note, the total estimated need for HS was 4.5 million. That should say 5 million, and I'll fix that.
Okay.
Resend it. What happens when you throw things together at the last minute? Failed half a million.
In your defense, the top line was 4.5.
Also,
I'm trying to defend you here
defend me from myself.
because it was,
Oh, yes,
it
yes,
was
yes,
2 years at 4.5.
yes, yes, thank you.
A lot of numbers in your head. Thank you.
Perfect dollars. All right, that's right.
All right, so let's start. So we're gonna go back to section 10. Everybody's favorite section. Jill, wanna come on up?
Yeah, so I'd like you, Madam Chair, if it's okay, is come up together with Sandy Roos, who's here from one of our agencies.
Absolutely.
Just kind of together.
Yep.
Thanks. This one actually knows a lot.
Okay.
I'm just gonna tee it up a little bit. And
And tell yourself
Yeah.
short.
navigate on the policy.
I feel like I'm in the position of all witnesses giving positive affirmation to today.
We could use them.
Would you like me to swear them in? Madam Chair?
I've
Slide
been
it down.
asking if we could do that, but apparently we can't, but.
Wow. Of my font for the vote of confidence. I'm Jill Olson and I am the Executive Director of the VNA of Vermont. Let Sandy.
I'm Sandy Roos. I'm the CEO of Central Vermont Home Health and Hospice, and I am a member of the Vermont Health Information Exchange Steering Committee.
So you see why I brought her. Bear with me. So just to sort of tee it up a little bit, we don't have any particular concerns with this section, and I see that Vital was comfortable with it, and so that we would really be following the lead of Vital on this. But I thought this was a good opportunity, since you wanted to hear from the provider community, to talk a little bit more, for you to hear more about how medical records work in the operations of home health, because it's really different. And that's why I wanted to bring Sandy along, since she's has that operational depth as a leader of an organization, and also her role on that HIE committee that already exists that's referenced in the bill. So I'm gonna turn it over to Sandy, but I'm gonna, just be here just in case. Yeah.
So good morning, everyone, and it's a great opportunity to be here. I do want to say that, and echo what Jill said, that we do support, obviously, interoperability and sharing of clinical pertinent information across the system. We continuously talk about the continuum of care and how important it is, certainly to our work. And we work very closely, obviously, with the whole healthcare system in many different capacities and ways. I do also want to talk about, we do share information with Vital. We share admission, discharge, and transfer information, as well as CCD information, continuity of care document information. So that does go into the current health information exchange. And we are looking at a few other things as well. In addition to that, I really want to talk about home health and our EHR systems, and just through the lens of what does it really look like. And it is quite different than when somebody walks into a visit at a doctor's office and or in the hospital setting. And I think about it when our staff go into a visit, and some of you may have had the ability to have home health. I certainly have, my husband has, and other family members. And that patient may answer the door, and immediately we're going into assessment mode. We're looking at their gait, we're looking for falls risk. We're also looking around the house and our home to determine where are we going to sit, what is improper infection control situations for procedures that need to be done, et cetera. And then we conduct our visit. The one thing that we are experiencing currently is we have an EHR that actually is a hospital-based system with a home health module. It does not support our workflow. It is not intuitive. I've been in the field with staff and can see their workflow. And that's the one thing we'll be looking at differently as we explore to implement a new EHR. And we'll also be looking at interoperability and all of that. But ultimately, you know, in a practice, it's very easy to sit down and go through your meds firsthand, right when you walk in the door and all that. Our system is built, you got to start with demographics, this and that, and go down this list. And that's just not how it works. So if you don't go down that list, it's really not helpful to the clinicians in the field to be able to do the best work that they do.
Do all home health organizations use the same EMR or you're all different?
Several of us do.
Yeah, there's
actually.
probably 3 or 4, I would say, primary home health EHRs that are used across Vermont. There are several, you may remember well, you may not, because a lot more happened, but in December of 2019, so you remember what was coming next for all of us, there was one of the home health medical records actually had a major ransomware attack. And so it impacted 3 of our agencies. So it was at their sort of national level, but it impacted the operability of 3 EHRs, and that company is essentially gone. And so 3 agencies had to replace their EHRs just based on that event.
Mari,
Yeah. But they are home health specific
they're
EHRs.
designed for.
They're designed for home
Right,
health,
exactly,
designed for
to
work in the
support
field.
the workflow.
I think one of the most important things in developing a module for a particular group is that the people that do the work get to be
Have input.
designing it, otherwise it won't work. And
Exactly.
I've experienced that personally, where home health able to be involved in the design of the system that you use now.
No, it wasn't.
So there's a difference
yeah.
between what the technical functionality or
Absolutely.
potential is for the software and then how it's designed to make it work for the people
Right.
who are going to use it.
Exactly. And I certainly know what you're talking about. We use a PBM for our hospice, and actually nurses and individuals that have done hospice and are doing hospice have the ability to have input into the formularies and all of that, which makes a huge,
Yeah.
huge difference.
Yeah.
So thank you for that. In addition to that, home health agencies, a lot of us have different programs. So we have our skilled care, which is the majority of our work, using, you know, RNs, rehab therapies, et cetera. But then we also have family and child health. There are nurses in that as well, but a totally different approach. We have long-term care. We have hospice. Even though hospice is medical, it functions very differently from home health. So the EHRs it's very hard to accommodate those. So having a system that is built around a home health setting really kind of takes all of those things into consideration versus just that regular streamline of skilled care. So that is just something that we need to be really thoughtful of when we think about changing our systems, or when we think about talking about data integration and data sharing, and how we can accommodate the really key pertinent areas of the system. And I know there's many. And ultimately, our goal too, when we think of a system, we think of staff satisfaction and staff retention, because that leads me into limited resources. And these systems, you know, there is a really keen eye from employers, and I'm sure many of you have experienced that or are experiencing it, that we have to support that because we need to retain people to do the work, especially in the healthcare environment. So also when we think of the current agencies, we've had 3 agencies that just had to switch their system not long ago. That's a huge investment. We have gotten no funding, you know, like meaningful use and all of that.
Yeah.
Home health agencies weren't on that list. So yes, we have the ability to fundraise, but we also have to use that fundraising to support our everyday operations. And, you know, that's also something we want to consider as a system. And when I say system, holistic healthcare system across the board when we're talking about data integration and data sharing. And certainly limited resources. I mean, for all the limited resources we have in other areas of the system, I was just recently down for 2 weeks, you know, running the hospice team. So we don't, there's, you know, there's not a lot of layers in the organization, and we do what we have to do to serve our community and our patients the best way we can and to support the staff we have to be able to do the work they need to do.
We need 3 organizations that had to switch. I'm sure that there was a cost. However, I'm wondering, was there any way to calculate the cost on efficiency or morale, for that matter, if that was considered?
Like, I'm pretty sure, I know in talking to 2 of those directors, that was, even though there was a more immediate had to do, that was part of their whole process and looking at that.
Yeah, they
Jill,
took
you can
years,
certainly-
they took years to fully sort it out. They
Yeah.
did a really intensive process in terms of evaluating the different EHRs, the needs of their agencies. Yeah, and I actually don't have the list in front of me of exactly which EHR each of them
Right.
chose. I'm not sure they actually
Yeah.
all chose the same one. I think they did different ones.
I think 2 of them chose the same one and
Yeah.
one didn't. And a lot of the systems now actually have interoperability bi-directional capabilities. Although there are larger systems out there that are very proprietary and they don't want to play in the sandbox, for lack of better words. I'm just going to say it. So, when we think of that data integration and data sharing, those are also things we want to think about as we work with vendors to say, this is part of the deal. And and I think too, I want to get into, when we talk about resources in our world, efficiencies is key. So like I said, I'm down running a hospice team for 2 weeks and I'm the CEO of the agency. And, that gives me great gratification and I know the staff really well. And frankly, I probably know 80% of our patients that are on service. So to me, it's very meaningful and it gives me a different lens to look through for lots of reasons. But ultimately, Medicare has cut our rates over the last 11 years, over 40%. So when we think of efficiency, I need systems that support our work. Technology is a tool and it has to support our workflow. So as much as we want to integrate and share information, we also have to think of things. And I always think of things from a 3-legged stool perspective. If one of those legs breaks, the stool falls over. And that's what I talk to my staff about all the time. So ultimately, we're really trying to balance all of these things that come into play. And from being on the Health Information Exchange Steering Committee, I know a lot of this is talked about and there has been discussion certainly around data integration, data sharing. What does it look like from a state perspective to be on one system, and just wanting to make sure that any information that feeds policy is integrated with that as well. And Vital certainly has a presence on that committee as well. So.
Sandy, I'm not sure. I think we might have interrupted your talking about just sort of that workflow and what, how the charting actually happens. I just think this is important for the community to hear.
Too.
Yeah.
Lots of times there are pertinent things they're documenting during the visit, such as medications or that assessment of, falls risk and certain things that actually we have to monitor in the sense of goals that we're trying to achieve and improvement. But in addition to that, beyond just that quick documentation, the rest comes out the door with them and they're either on a tablet or a laptop, not necessarily connected to the internet, doing their documentation.
In
so
the
those
car.
are all things in the car. So those are, once again, other things we have to think about, that they're not at a desktop able to access, that familiar place that they're in. And like I said, in the home, they're looking for that space where they can actually set their equipment up. On the flip side too, if they have MRSA or other types of things like that, then we can't even take the equipment in. So, it's just a really different environment to consider as we think about data integration and data sharing, and when we think about systems and what does that look like for the continuum of care in every aspect. So sorry about that.
Yeah. I mean, the charts have to work in the car with no internet.
Right.
It's really, really different than a hospital or a physician practice in terms of how the documentation works and how it happens. Plus, we have a special assessments that home health has to do that are different than anybody else. They're federally mandated assessments. So the EHR has to follow all of that. Yeah. It's pretty individual to that part of the industry.
Any questions? Tupper?
As the Agency of Human Services, have you been in contact with the agency at all? Excuse me, over the last year, talking about collecting data and the the patient's record?
Well, Sandy serves on the HIE committee, and so that's sort of, I think, our primary conduit
Right.
to talking about these issues
Yeah.
is that committee.
Right.
Yeah.
And a lot of that discussion currently is still focused on the hospitals. You know, but as a representative, I do bring those things up when we do have discussions around, you know, where does that play a role in all of this?
Yeah. But all of our, you know, we've had multiple conversations and with Vital too about making sure that home health agencies are participating in the health information exchange, which they are. That the health information exchange is our mechanism to share data between different types of medical records. That is the mechanism, and we are participating. I think that's the point I want to make sure is that we're getting across.
Any other questions? I guess I have one. This is gonna be my theme question of the day today. So section 10 envisions an integrated system of clinical and claims data in order to improve patient, provider, and payer access to relevant information and reduce administrative burden on providers. Is there anything about having an integrated system of clinical and claims data that you feel that you can't get from Vital, that you feel would reduce the cost of the care that you provide and create greater efficiencies and allow you to do your job with more efficiency and less cost?
I think for me, it would be helpful if that data was easily able to be accessed through our current system.
So sort of an interface.
Correct.
Okay.
So you're in the current record and you can
Right.
see the information that might be relevant.
Right.
Yeah.
Information, you can pull information from Vital.
Versus having to access a separate system. Currently, we access multiple systems. But being able to potentially consider that, and I do believe there is testing going on with one system currently that I've heard about through the HIE steering committee. But ultimately, I think that would allow providers across the continuum to actually really use that data versus having to have somebody else kind of mining that data and putting it into the system, which is an additional cost. That person be doing that.
Would you be interested in clinical data or claims data or both?
Primarily clinical data.
Well, and actually it raises another point that we actually didn't talk about that I think is also important for the committee to understand, which is that the EHRs are fully integrated with payroll and claims.
Right.
So the idea is to be able to use the EHR system to feed
Right.
both the payroll, did you work, and the
Billing.
billing
Right.
in one integrated way. So anytime anybody talks about making any changes that touch any of those things or billing somehow outside of our EHR billing process, that's when it starts to cost money. We have to stay in the integrated models.
Yeah, so currently our current system feeds both our payroll system and our billing system. So it's one system that really does it all. And we don't have to have these middleman systems that we have to manage and pay for and all of that and maintain.
I just want to make sure I understand how you're hooked into Vital at this point. I'm the patient. You come to my home. Can that nurse go into the system and look at my health record?
I know they can access medications and different things like that. What I do know is when the UVM Health Network actually went down, where they had that cybersecurity attack several years ago now.
Yeah,
It
it's a couple
seems
years
like it
ago.
was just yesterday, but it wasn't. I know the physicians were actually able to go into Vital to see our information, which was really helpful. So like our medical director told me, he goes, yeah, I could go in and see like your last note and all of that. I haven't looked in it from the clinical note perspective, but we've looked for pertinent information. Certainly medications, tests, that we'll need to know that determine our treatment plan, et cetera.
Yeah, I think it's important to think about the fact that actually getting every single piece of information and every single note is probably going to be unhelpful because you can't
Right.
absorb it all. So really
Yeah.
what the nurse is looking for is key results, lab results, key diagnoses, medications. They don't necessarily need to be able to read on the spot every single thing that ever happened to that patient with their, remember what medical records used to look
Yeah.
like when they're on paper?
Right.
You don't want to do that sitting in a visit, right? Because that's more than you're going to be able to make new stuff. So it really needs to, I think this is going to be the challenge, is making sure that the information that we're sharing is what people need to do a better job in the field.
All right.
I'm assuming you have a downtime procedure for when, if and when the EHR crashes,
Yes,
so
we
that
do.
you have a way of
We have
accessing
offsite. We're cloud-based currently.
the most recent
Yes.
critical information,
Yep.
like you were just saying.
Yeah, we're cloud-based now, so actually, if our system goes down, there's a, we get right in through the cloud, so, and then our cloud-based system has a backup, so we have had that happen, where the cloud went down, and then they transitioned us within 30 minutes to, another setting. And so when our staff are out in the field, ultimately, they're not connected to the server all the time anyhow. So lots of times they're leaving from home and ending at home. So they don't even necessarily come to the office, only for meetings and, if they need pertinent information, supplies are delivered directly to the home. But we do have some supplies on hand at the office that they'll come in for, and all of that. So.
Leslie, I'm just trying to understand the process of referral. So I'm imagining that you and your staff are getting the referral
Mhm.
from likely a hospital. And how does that integrate with your use of Vital? How does that work?
So ultimately, when we get the referral, that's information directly from the referral source.
Is that on paper?
Yes, no, actually, it's all electronic.
Okay, so
Right.
you'll get an electronic referral from the PBM, wherever.
Yeah.
How does that work with Vital then? Do they overlap or do you use both?
Right, we don't necessarily plug into Vital, just from one referral. We'll go out and do the assessment. If there's something that we think we need that we can't get, certainly we have access to different systems to actually pull information. So we may have our intake team go in and look for some additional information. And or if it's something really complex, we do have a whole division that deals with our really complex patients. There may be the ability to access Vital Access to see if we need additional information.
So does Vital enhance, how does Vital enhance your work?
Yes.
Differently than how does that, how does it do that?
So ultimately, I think the best information that we can get from Vital certainly is related to medications.
But that wouldn't be on
And then-
referral?
It would be, but what happens is pharmacies and all that. So lots of times we get a referral of medications. We don't just rely on that medication list. That's the whole
Yep.
concept of being able to go into the home. And even then, if somebody's filled a script, that's different than what's on that list.
On the referral list, but the Vital list is more up to date than the referral?
Yeah, the pharmacy also feeds into those lists. So inevitably with medication, you still have to, medications, I think, is our biggest.
You still have to have that one-on-one
Yeah.
confirmation.
Medication's not really a
Medications
technology
is-
challenge. It's
yeah.
really it's a much more of a people challenge.
Yeah.
Are you taking the medication that you filled? What's in your I mean, I did my mother's medication
Mhm.
reconciliation. It's terrible. Her doctor thinks she's taking one thing. She filled that prescription. She's not taking it. She's not taking it. And you don't know that until you're in the home.
And how does that information get back to the the clinician and to Vital?
When we reconcile the medications.
So it's directly integrated. That's where the integration comes in both directions.
Yeah, so ultimately, if we find a medication that a patient is taking, we actually update the doctor, so they certainly know.
Mhm.
And then ultimately, they have different systems too that talk. Probably, I would say hospitals and physicians are definitely more integrated with the HIE than we are. So,
Yeah, especially them taking information from us.
Right.
Yeah.
Yeah, I'm just trying to understand how it all fits together and, or not.
Great, thank you.
Thank you very much. Thanks for the opportunity.
thank you.
Worked really well together as a team, I would say.
Well, Sandy recruited me into this job, so we've been working together as a team for a long time.
Hi, Devin. Hi. You're next. Okay.
Running up and down the stairs.
Good morning. Thanks for letting me catch my breath. Devin Green, Vermont Association of Hospitals and Health Systems. And I unfortunately, Emma Harrigan, who normally she runs our IT director meeting, she might be able to get on the Zoom. She has an appointment right now. I talked to two IT directors at hospitals. One is on vacation, one is at a conference. So you're going to get me on this issue today.
We have lots of other people that are actually in the room. If Emma is at an appointment.
I don't know if she'll be
get
back.
bumped to the end of the list.
Okay, she doesn't. It's at 11 in Montpelier that she has to leave for, so I don't think it would work out anyway. But this is all to say, I'm going to give you a high level sort of overview, and then if you want to get into the details, we will have people back and they can come in. We also have an IT directors meeting regularly that you could all join and ask as many questions as you want. So I definitely want to make sure that you get all the expertise here. And so today I'll just give you high level. And ask questions now while you can because Emma's on the Zoom. But I'll go through this fairly quickly. Emma. So I know you are asking about section 10, and that is largely about integration with VCures and clinical data. We are much less concerned about that. We are much more laser focused on interoperability between hospitals. We know that just doing that will be a lot of work. We understand the need for interoperability with community providers, but we think we have to start with hospitals first and get that to happen. There are a couple of different options for doing this. One is, we have four major EMRs in the state. And I'm looking to Emma for that. And there are currently ways for them to talk to each other. So that's EMR to EMR. There's also going through the HIE, which is vital. And then there's things happening on the national level with the Trusted Exchange Framework and Common Agreement. So when I talk to the IT directors, they are very hopeful going into the future that this is going to be much like the evolution of the internet. The internet started out at large companies, IBM had theirs. They all weren't talking to each other. They were pretty turfy about their own systems. And then we did come to a place of good information sharing. So the direct EMR to EMR connection, we're putting energy in there now. The pros is that you don't have to buy a whole new EMR. You can use your own EMR and connect. You do have to sort of build it. And so we want to be careful about where we do that because it is not without cost. It's a little hard to maintain and it's not scalable. So I think our next steps are just looking at what are the real where will we get the most bang for our buck by doing that across all hospitals? So I think that there's work that we can do there. The HIE connection, which is vital, and Emma can speak a lot more to this. That is pros because bidirectional exchange of records, it's a single setup, it's inexpensive, it's scalable. The cons are really in the user experience. You've heard providers talk about clicks, and the more clicks they have to do, the less they're going to do it. It's a barrier. If they have to actually go out of their EMR and go into a whole different thing, then that's like a no-go. My understanding is Vital is really working with EMRs to ensure that they're integrated more and that people can stay in their own EMR to get to Vital. So we see a lot of opportunity here, and perhaps between that sort of direct EMR to EMR and the HIE connection, we can really make good strides. And Emma, I'll let you add anything to that.
Thank you. Good morning. Emma Harrigan, Vice President of Policy with VAS. I also serve as the chair for Vital, so I am on their board. Devin covered it well. I think the other thing I would add is that the HIE in Vermont has very robust information for Vermonters. With the change in our opt-out policies, I believe we now have over 95 to 95% of Vermonters our information is available in Vital. Beth Anderson can better quote those figures for me. So we have a much more robust data source that can be used for connecting providers with information through the Health Information Exchange. I think the other thing I would add is we have very robust HIE connections with major EMR vendors, so Epic and Cerner, Meditech, CPSI, which is now TrueBridge. I think those connections are really strong. The remaining challenges will be connecting smaller, less familiar EMRs in Vermont, ones that are maybe more used by independent practitioners or specific facilities. So that's work that Vital is engaging with.
Can I interrupt you really briefly? I'm sorry. Mari, did you?
Yeah, just a quick question about what you brought about with the clicking and being able to access HIE from within an EMR. Are there, is anyone having success with connecting with HIE from within the EMR?
I believe we have 1 or 2 hospitals that are directly connected, so it is integrated in the EMR. I don't have the specifics, but I could follow up with Vital, or if Beth is presenting, I think she may have more detail.
That's okay. It's good to know that it is happening and it's possible.
Yeah.
Thank you.
I have one simple question. Is there a reason why? Is there a reason why you're not connected?
Like all the hospitals are? Because we are on those 4 different electronic health records platforms.
Well, aren't they supposed to? Okay, go ahead.
And yes, initially with the Affordable Care Act, there was supposed to be interoperability. It just hasn't happened. I think we are getting there. Like, I think we're starting to see movement towards that. And I think with the tools we have today, like the fact that Vital's getting integrated into our EHRs is very helpful. I think the fact that the platforms are making portals that allow our hospitals to go between platforms is helpful too. Like, there's progress being made, and I think our work in the ops session is to figure out where to really put our efforts to standardize it, to try to make it all hospitals in Vermont. And then again, where we'll get the most bang for our buck.
And if I could clarify, and again, I will get more concrete numbers. I believe all hospitals in Vermont are sharing and receiving data from Vital. The difference is the user experience on how hospitals can access Vital. We have 1 or 2 hospitals, I believe, where it's just integrated in the EMR. So if you're thinking about the EMR like a web browser, it's just an extra tab. Where other hospitals, it may require them to go into a separate clickable space where they have to enter login information. And so I think there's different degrees of how that experience looks like for hospitals, and the degree to which it's seamless depends on, the ability to work with Vital for that particular EMR. So it's just working with those different vendors and getting those connections up and running. And I believe Vital's website has a page that shows you every single provider and facility in Vermont that is connected to Vital and whether they are sharing or receiving information from the health exchange.
Yeah, my understanding is we're all sharing, all the hospitals are sharing and receiving. It's a little bit like Jill's mom, and is she actually taking the medication? Is the provider actually using it? The last piece, which I would be more positive about if things were different, was there is this sort of national movement at the federal level to get to a nationwide system. Our IT director were feeling really positive about this a couple months ago. I think with where the feds are at now, this is a lot more uncertain, but they were, it was going in a great direction previously. Hopefully that work can continue and have, robust data privacy involved as well. Additional thoughts that we have on all of this is to, as Emma was saying, improve system design. Workflow really matters. The clicks, think about the user. How can we reduce barriers for folks getting to the data? And then we know we need to start here with hospitals, but regional connections would also be very important. Our hospitals work with Albany often, and Bay State and out-of-state hospitals. So we are constantly talking to our colleagues and thinking about this, and hopefully we can get movement there. And then the most important piece is good governance over the data. So really, if anything's going to change or be set up, how do we put a good governance process in place so that the data is used well and there's sufficient privacy? And yeah, so I will leave it at that.
Any questions for Dr. Yeah.
So the difference between what this is, what AHS wants to do, and what Vital already does is the tracking of transparency of billing. Is that? I'm really struggling with trying to figure out the difference between these two.
Can I correct something though?
Yes.
Something that you said. I don't believe AHS wants to. This was not brought by AHS.
Okay.
To be incorporated in this bill. They just commented on it yesterday.
Okay.
What we're mainly saying is, all these other things can happen. Again, we're really laser focused on the piece of interoperability between hospitals. As you heard Joe Wooden say, we don't want people doing multiple tests. We want to have that data flowing. So,
and right now
that's where we are with this.
Is Vital the one that's the most, I guess, is that the one that everyone is focused on right now?
Vital is helpful, but again, there's a little bit of a user, we need to get the providers to use Vital. And in order for them to use Vital, it needs to be more seamlessly integrated into the EHR. And we know that that's happening. And as Emma said, it's happening at 2 hospitals now. We're happy to have those folks in to testify about it. But that to us is hugely important. If we could make Vital more integrated into our EHRs and make it more accessible, easier for providers to get to, I think that is a game changer. I think Vital recognizes that too. It's just hard work.
I don't know if anyone remembers because it seemed like it was ages ago, but we had Vital in and they talked with us about how their next moves and the things that they're working on now is to have interoperability within systems. So I'm thrilled to hear that there are 2 hospitals that would be really interested if we could get somebody from one of those 2 hospitals to come in and see how it's working in real practice.
Yeah.
And if it's helpful, Daisy has a question and then Topper has a question.
Well, first a comment. We've heard a lot from providers, including around the table, about the clinical or the improvements we can make for clinical use. And I'm just a little concerned because I don't hear a lot about, like, from administrators and people who would be looking for technological improvements to make operational improvements, which is what we really need in this system. And I think what the bill is really getting at. And I'm just curious if you or Emma have anything to say about where you're looking for HIE or HIT supports that really help administrators to monitor quality and make improvements there with these technologies.
I mean, I think I'll just start off with clinical improvement is operational improvement, right? Like if you are able to better coordinate care through technology, you are providing better quality care, you're reducing the cost of care, you're not duplicating care. And so that's why the focus is on the clinical improvement piece, is to make sure that people get the information they need so that those things, the duplication, all those things don't happen. So I think that there is a huge operational component to the clinical piece. I think for quality, I'll let Emma speak more on the quality side. Because you mean like quality, like measuring quality, like quality measurements and making decisions off of that, or?
Yeah, I mean, Emma and I think, have talked about this in the past about, developing better workflows, your KPIs, and comparing, especially across the system, at who's doing well by diagnosis code. I think there are elements of the bill that kind of fell out where we're going to identify some of those in the task force. And so, we need to have a tool to do that. This could be part of a tool. And I'm just curious if we're giving, your folks at the hospital a chance to really weigh in on their needs in terms of, a tool that is going to give the measurements they need in order to make those positive changes that are going to improve our system.
Yeah, I would say, let me go back and get the specific needs there and come back to you with that ask.
And I can say, Vital's mission and vision is to create a tool that creates a single health record for each Vermonter for the purpose of improving the experience of delivering care and improving patient experience of care. That being said, I think, there are technology efforts at the Agency of Human Services and in partnership with Vital and maybe some other organizations to examine what that next layer of support looks like for healthcare organizations and facilities. And the Health Information Exchange Steering Committee, which I think is referenced in Section 10 of the bill, meets pretty regularly to look at like all of these issues together. And one thing that has been explored is whether healthcare in Vermont needs analytical support. Do we have the right tools or the right definitions and the right governance for us to ease the administrative burden on individual facilities, some which may not, outside of the hospital sphere, may not have the resources to develop analytics and look at those KPIs at the same level of robustness as a hospital facility can. And so how can AHS or Vital or other partners come together and build kind of like a dashboard or some sort of analytical support so that if there are KPIs or quality measures or performance measures that we are expecting providers to look at either through a performance lens or payment reform or just for individual management of the facility, that they have a tool where they can access that information and that they know that the data is robust. There's transparency in how the calculations are created. So I think that's part of the vision of it's a topic that's come before the HIE steering committee several times in the past couple of months. And so I think there's some work underway to build out what the requirements would be for that kind of tool. And that should in some way involve Vital, or that Vital is providing their feedback to that process. And hospitals are as well.
I love to hear that because I think we continue to focus on, I never thought I'd say this, but the patient experience and the provider experience, and I cherish that. But also, I think this is such an opportunity to talk about really making some practice improvement across the system. And I want to just lift that piece up. So thank you, Emma.
And I will add to that, that we have heard from hospital leaders who are worried about losing the data that they gained through OneCare and wanting to preserve that to make those decisions. So I would advocate for that.
Different section, but no.
Yeah, different section.
Upper.
First of all, I want to tell you something first. I am not trying to set you up. The reason I
Okay,
say that,
I'm gonna put a helmet on now.
the reason I'm saying that is because I was involved when Vital was set up.
Mhm.
And I know all the intricacies and all of that stuff, and we worked it out. Now, my question is this. Are hospitals 100% behind section 10?
I would say that section 10 and I would say we're neutral on section 10.
Neutral?
Yes,
Now, how can you be neutral? And tell me how you can be neutral.
because a lot of section 10 is about integrating claims and clinical data. And while that could be helpful, at a higher policy level, we feel real urgency around interoperability interoperability between hospitals and of the clinical data. So that is the work that we are doing.
And I just want to follow this along.
She's got
There
a
are
helmet on.
there are three words in here that may be different. I can't remember whether we used the word may or shall when Vital was being set up. But this says shall. And it's pretty clear. It's got to be done. That's why I asked the question. Are you 100% behind? And when you say neutral, what that means to me is the same fight that the hospitals put up, and especially UVM, of not getting involved with Vital the way they should. They went off on their own. They set up Epic, and
I mean, UVM is connected to
I
Vital.
know they are now.
Yeah.
Yeah, they had to have an interface to be able to do it. But in the beginning, Vital was supposed to approve any medical record system that was going to be set up. And that was a big fight.
Okay.
That's why I asked the question about, are you 100% behind? If you're neutral on it, that means, to me, we're going to go through another 18 years or whatever years it was of back and forth, instead of doing it in the best interest of the patient. That's how I feel.
What I will say is when we brought this to our data people, they were less concerned about this. They're more concerned about interoperability. And so I will let you know if we're going to put up a fight. You will know if we're going to put up a fight. I wouldn't.
We think we all want to be on this thing, on the same track here.
Can I ask a question that's to follow, and would, rather than being neutral or agnostic on section 10, would hospitals be in favor of moving Vital further along in accessibility and interoperability and
Yes.
and all providers sharing data?
Yes.
Okay. Thank you. Are you all set?
I'm not going to be around here for 18 more years. I want to see this thing happen as soon as they can.
Thank you, Devin.
Thank you.
Thanks,
Thanks,
Emma.
Devin.
Thank you, Emma.
Oh, I'm sorry, Woody.
Is there a cost to our hospitals with this system?
My understanding is no, that is passive. I would certainly be concerned if there were administrative costs or time and resources costs, but my understanding is that is not how this works. And if I understand that differently than anyone else, please let me know.
And if a national system were to go into effect, it would be a good thing as opposed to having Vital, right? Or will there be integration with Vital?
I mean, I feel much less
know we're going
hopeful
down.
about the national system going into effect. And given where we are with data privacy and how health information is being used, it feels less of a definite good than it did
Yeah.
a couple months ago.
Well, here again, I'd like to know if there is a cost involved with this with the hospital.
Yes, I would too. So I will double check on that. Thanks. Thank you, Emma.
Thank you both. All right. Mary Kate?
Good morning, Madam Chair, members of the committee. So thank you for having me, Mary Kate Molman, Director of Vermont Public Policy with Bi-State Primary Care Association. And I'm here to speak about Section 10 from the perspective of what is Bi-State doing with data? How are we working with data and our FQHC members? I am also a member of the HIE Steering Committee, and I also was the health services researcher for Blueprint for Health for a number of years. So I have that experience kind of working with the data. And Blueprint for a very long time was really one of the leaders on using integrated claims and clinical data in reports, and actually did some nice publications, published journaled articles with the data. So generally, we are supportive of Section 10, and I would defer to those with more technical involvement, such as Vital, around sort of how to evaluate Section 10 from that technical perspective. So I'll be coming more from the data use side. What does Bi-State do with the data? We have, so you could call it an arm or a sub-organization. It's a health center controlled network. This is a organization supported and funded by HRSA and tasked with providing data and analytic support to FQHCs. There's, we have one in Vermont, and a number of other states also have these HCCNs, the Health Center Controlled Network. Ours, we call the Vermont Rural Health Alliance. And we really work very carefully with each of our health centers, going in, working with them, looking at the data that they have, helping review the data, analyze it, and then think about how do you incorporate that back into quality improvement initiatives. We also are able to, we bring in Medicaid claims data. We have a contract and a MOU, data use agreement with DVA to ingest the Medicaid claims data for our members. And we were able to link that with the clinical data that we also receive from our FQHCs. And some of the data that I think is the most useful to our members is the eligibility file for Medicaid. As part of the claims information. And we really use that on identifying members or patients who may be coming off of Medicaid soon and they need to re-enroll, or if they're no longer eligible for Medicaid, what other insurance options or coverage options do they have available to them so that they maintain a continuity of coverage. The other one we really use a lot is that EDT, which is the, I guess, electronic transfer and discharge file that comes through the clinical. And that's something that's really important to understanding if a patient goes into the ED, what kind of medical medications were they given so that our members, so the FQHC can do a med reconciliation for that member and do any follow-up to make sure they're getting the prescription they're How does it work with the other medications they're receiving, et cetera? So that's how they're using it. More generally, when it comes to integrated data use, I really think of it as 3 levels of data use. And I think I've heard people sort of get at this, but I want to just be really explicit in how I think about data. There's the first, which is kind of with the individual, your point of care, using that data in the appointment with your patient and helping provide that care. There's the operational quality improvement. This is sort of, I think, about the organizational level. How are you using data? How are you identifying patient management, panel management? How are you doing outreach to your patients? How are you setting up your workflow within your organization to best manage your patient population? And identifying staffing needs. And then there's kind of the highest level, which is the evaluation. This would be like a longer look back, looking at a policy change that we did and how did it work? Did it accomplish what we wanted to do? The audience for that highest level is really the legislature and I would say administration. That's not what our clinicians, I mean, we may have some clinicians who would be really interested to see the like that evaluation journal article and feed it in, but most of our members don't necessarily need to look at that level of data use. So I'm going to focus on the first 2. The point of care at this point, I would support what Devin was saying around the need for interoperability. And it is difficult at this point with the integrated data to really use it in the point of care. It really needs to be packaged in a way that a clinician needs to be able to look at it, have it one click, identify what's new, what's changed, what is most relevant to the patient in that appointment that they can discuss at that time. That we are not there yet. I think there needs to be a lot more advancements in the interoperability and how data is then available through the EMR. Because sometimes it's in very disparate parts of the EMR and there's a lot of clicks to get all of the information compiled. Yes.
Can I just stop you really? Do all FQHCs in the state of Vermont, do they all use the same EMR?
No.
So they're all on different EMRs?
Yes.
Do they all feed information into Vital?
I believe most of there was one health center that was having issues because of the Part 2 problem. They weren't able to separate out the Part 2 data. And so they didn't feed any data to Vital, but I would have to check to see if that's been resolved.
Do all FQHCs have access do they all retrieve from Vital?
I believe so.
Okay, thank you. Just wanted to say that.
But in terms of like an integrated claims clinical access, which is what I believe is envisioned in Section 10, at this point, it would be less of value until it's really easily accessible and packaged well. The operational, I think that's where the most opportunity is to understand both what are the utilization trends of their patients, what are the clinical outcomes of their patients, are we seeing a trend in one way or another, or for example, the A1C is a typical clinical measure that a lot of people and researchers reference, and it's usually one of the measures that is called out in any program where we're looking at quality of care. But looking at like, as a population as a whole, are we seeing positive trends in management of A1C? Are we seeing individuals with diabetes and comorbidities better managed across multiple providers? And so understanding both the utilization and diagnoses and clinical outcomes is of value in understanding how to improve that patient flow, panel management, operational staffing, et cetera. And I think but the caveat to that is that data also needs to be available in a way that is actionable. It needs to be actionable information, not just raw data. And that I think is a key thing. We often use data and information interchangeably. Data is your spreadsheet where you're looking at it and you're playing around with the numbers. Information is something you can look at and be like, oh, okay, this is what I do with, this is what all of these numbers tell me, and this is how I apply it. And that's really what I think a lot of our members need support in, especially the smaller ones. And I would point to the Blueprint for Health. One of the things I think the Blueprint for Health did really well when it was set up is they started out as the, I forget what their program facilitators, but now they're the quality improvement facilitators. And one of their key roles is to work with primary care practices across the state to help interpret their data, help interpret what they're seeing in this information. And one of the things that they used to produce were practice level profiles. They still do the community profiles, I believe, but they used to do a practice level profile. When the ACO and OneCare came on board with the all-payer model, some of that reporting shifted over to the OneCare, but I think we're going to need to figure out how to bring that back. And so having QI facilitators, having access to those practice level reports, and then sitting down with the clinical staff out of practice and say, hey, this is what I see. This might be some of my recommendations. And because they're working with multiple practices, this is what we saw work in this practice. This might be something you want to try here. So it's not only helping package and recognize what to do with the data, but it's also sharing best practices across clinics. So that would be, I think, the best potential use of what is envisioned in Section 10. And the last consideration I would raise is also to back up what Devin and Emma were saying, data governance. Data governance and transparency on how data is governed is key, because that is the key to gaining and maintaining public trust. And if you don't have public trust in how you're using data, and the quality of the data, then the foundation starts to crumble. So it's really important to have a transparent data governance apparatus in place. And there is the HIE steering committee. There is also the HIE Data Governance Council. I think it's a council. And they meet every other month, I believe. It's on the HIE website. But that would be something to continue to lean into. And I don't know if you want to reference that in Section 10, the importance of governance.
Any questions for Mary Kate?
Just a comment. It's mind-boggling to me, all the different agencies within the state that have the potential access to all of this information. And each one may be doing different things with it. And as you said, data governance, who puts in the data? Besides looking at it,
Mm-hmm.
And also security. All these different agencies, how secure are they from security breaches and things of that nature? This really is an important item.
It is. And I would add one layer to that. There is risk when you integrate data, when you share data, there is always that risk. And so putting those security guardrails around it is really important. But I also want to call out the other risk of not sharing the data and not having different parts of, let's say referring to government agencies. If they're both working with the same individual, but not sharing information about that same individual, there could be potential harm by having conflicting either, I'm thinking of medications would be the easiest. If you don't have a medication, you don't know what the person is doing. If you don't understand the other medications they may be on, you could have an adverse event. Yeah.
Like everything.
I know, exactly. And that's why you need good governance.
Same question as everyone else. Having an integrated system that combines clinical data along with claims data. And you talked about Vital and having that as more of an integrated into, accessible. Is there anything about combining claims data and clinical data into one integrated system that is accessible to all that would add value to reduce the cost of care for providers in an FQHC? And additionally, I'm going to ask the question, would providers in an FQHC want every other provider to have access to their claims data?
I would say the value is in that operational QI level. And for especially the smaller ones, I'm not sure having direct access to that data is necessary, but having someone who can help package that data for them in a way that is actionable. And we're kind of having that, we sometimes call them data ambassadors, having that data ambassador be like, this is what I'm seeing, this is what you can do.
I'm concerned because I know that claims data goes to VCures right now and it is de-identified.
Mhm.
Combining claims data with clinical data stops it from being de-identified. And so all provider types would have access to all claims data, not de-identified. I'm sorry.
Why does it have to be de-identified?
It currently is de-identified.
It currently is, but is there a way to make it de-identified?
Doing this would de-identify, would identify it.
Yeah. But isn't there a way to match it up, like give every? Isn't there a way to match it up first and then give a patient a number instead?
So I think if I might respond,
Yes.
If you're talking about a patient level point of care, it would be de-identified because it would be all as part of that patient record and you're sitting down with your provider and patient are discussing, oh, I saw you got this test, I saw you got this test. This is the clinical outcome of that test.
Got it.
But if you're talking about that next organizational level, then you have more of an opportunity to look at the aggregated data for your patient population. And at that point, you could work with de-identified data.
But if we're creating an integrated system that incorporates both claims data and clinical data, then anyone on the provider side pulling out of the integrated system would have not only access to the clinical data, you had this here was the result of that, very useful information. They would also then have on a identified level, all the claims data on that particular patient, if it was all in an integrated system.
Yeah, the only thing I can think of is you could do a role-based permissions access to the data.
So who could see what?
Yeah.
Right?
But I think, sorry.
Yeah,
I
go
think the
ahead.
key is, to your point, it is identified.
It's identified.
So we are really
Yes.
changing
Yes.
the
Well, I
content,
believe
but-
VCures is currently now, you submit it, identified, and then it's
Mhm.
aggregated
Right.
and de-identified.
Yeah.
And so there could be a level of that. Now, if we get into that patient point of care, you would obviously, if it's in the patient record, it's identified.
But if that's the case, then what value does it give the individual provider, which is what we're trying to do to create a more efficient and cost-effective? I want to keep coming back to the point of this bill is affordability. I mean, we can talk all day about how great it will be to have all this wonderful data, but I'm struggling with how does this have anything to do with the affordability crisis that we're in right now?
I can give you an answer. One
Okay.
thing,
I'm having a philosophical.
your UVM, Gifford,
Yeah.
you can, UVM and Gifford, you have the claims data. You can tell how much it's being paid. That's the only, I see no other use for that.
Why does UVM get to know how much Gifford got paid?
I'm talking about people who are gonna look at this thing.
No, well, claims data.
If you're gonna try to reduce the cost, you have to know how much people are paying.
But we'd have that with VCares currently.
Well, then why can't we reduce it? We already have. it.
Those are
Why do
all
we need it?
wonderful questions, which is, I
Why do we
think,
need it?
why I'm asking the questions of does this do that?
Yes.
Mary Kate, thank you so much. Sorry to get you involved. Oh, yeah.
Yes, the claims data, I'm assuming it would be used for reference-based pricing. Is that the reasoning for it? And also, like you said, it will show how much is paid. Is that information also going to be showing whether the patient has the finances to pay for their care, or whether they've missed a payment or anything like that?
It's data on a claim that's sent to a payer. The payer then sends the claim that they received after they've adjudicated it, and it's uploaded to VCures currently, where it's de-identified and put into the larger set of all claims. And claims data, once it's been de-identified from all the specific patient information, it would contain the provider, the procedure codes, the diagnosis codes, and then the price, and then the probably allowed amount and paid amount. We can ask the payers this. So anyways, let's move on. I'm moving on. Thank you. Okay, Kelsey. Oh, and Simona, you're both coming up at the same time. Great. Hi, good, how are you? We are gonna have to find what happened to our other chair. I took a cushy one. We had two cushy ones.
This
One.
Oh, you're absolutely fine. Just have my very organized notes. Hi, thank you for having us. I'm Simone Rischemeyer, Executive Director of Vermont Care Partners, and been involved in health information exchange for a long time.
And my name is Kelsey Stavseth. I'm the Executive Director at Northeast Kingdom Human Services, which is part of Vermont Care Partners. I'm also the co-president of Vermont Care Partners.
Great. So I just want to start by saying, first of all, I've been involved since the SIM grant and was co-chair of the Health Data Infrastructure Work Group when we were talking about having one unified record for these patients. So that was a while ago. Here we are. At large, Vermont Care Partners is very dedicated to integrated data. Have integrated data for integrated care delivery. We've been dedicated to integrated delivery system for a very long time. I wanted to, I think the state is still working through full data contribution and user experiences, as you've heard from a number of folks. And I don't think that's any different for our agencies, getting into, I'll give you the state of the state for the designated agencies. And I will talk about designated agencies rather than specialized service agencies, because the developmental service agencies are not currently connected to the VHI, but the designated agencies are. So we are connected to a separate repository within the VHI. And that is because of 42 CFR Part 2, which is the substance use rule of the federal government that is still being worked on I don't know actually if it's being worked on currently, but it was, so that we could eventually hit that green light and have our data flowing into the VHI as well. So the first step is there, and all agencies are connected. Our agencies use two different vendors for health, electronic health records, and that was a big push. We tried to get on one, but I feel like two was a pretty good success. And we have a repository in-house where we have data directly from electronic health records into our repository on a weekly basis. We don't have claims, we have clinical data. So,
and the only thing I would add to that is that one, so we use two different EMRs. There is a group of folks on one that actually they create everything together. So it looks the same in their system. So, and then there's another group that do share the same system, but have developed all their own forms. So we have benefited from each other, but there was a real push to do a unified platform with the same form. So it would look the same at those agencies that adopted this NESMAR.
Yeah, thank you. And then I would just add that our IT directors, our quality and outcomes folks, our compliance folks, they all meet in separate groups. They all meet at least monthly to talk about best practice, what challenges they're having, and how to work, how to improve functioning and workflows. So that's also extremely helpful. That's 3 of our 30 monthly groups. So let's see. I want to just echo a couple of things that were said. I don't need to go into the detail because they were said, but the robust governance factor is huge. It's so essential for sharing data and systems and transparency around the interfaces and data sharing. And also that's also true for policy development. So as much as we're using data for clinical use, a lot of what I read within this section is also transferable to designing policy, and that governance and transparency is essential there as well. As the use of the VHI, I did phone a friend during the meeting as the other questions were being asked. But agencies do use Vital Access. The extra login is a barrier. None of our agencies have it directly into the EHR at this point. They use it for med management, care coordination, sharing of labs. And also Bamboo Health uses it, which is, it's not Bamboo Health anymore. It was patient pay, now Bamboo Health, yeah. Bamboo Health uses it, which it pulls ADT, admission, discharge, and transfer information from the VHI, and sends information to our agencies, which supports care coordination as well as follow-up and from the emergency department, follow-up visits. So that piece of it is helpful.
Do you give information to any of the designated agencies? Do you know, feed information into Vital or just retrieve it?
Currently, we have interfaces going. We built, the interfaces were built a year and a half ago. Data is flowing, but not to the VHI, to a separate repository within the VHI.
All right, thank you.
Yeah, at this point.
I'm sorry if I missed that.
No, totally fine. So that, yeah, and I think that, we've done a lot of work to streamline data and analysis through our repository and through our work towards the new electronic health records. We're doing even more now as we move to CCBHCs. That's an important component. It's more of an integrated delivery system. And so that integrated data is essential. I would say at large, probably most agencies would say something similar to the what's been said before, which is at point of care, it's essential to be able to share data and information with other providers and, for the client, patient, the individual. But for analysis of cost of clinical outcomes at large population health, I think that's really beneficial to have with VHI as well. And so,
I'd echo, the governance piece and is going to be really important. How to use the data is really important. But I think it's hard because when you look at this, some people are neutral saying, in general, we're supportive of the idea of it. It's like, how do you do it? And so what, or so that? Like, I think that's actually the key point. And so you mentioned affordability, outcomes. And so there's a couple technical pieces that come along with doing this. And so saying this is a good idea, but what does it mean on the ground for people doing the work? And so Peckin is picking up new EMRs, which are expensive. And then you need people who can manage and create forms in the EMRs. And then you need data analysts that can pull the raw data out of the back end and then manipulate it into something that is usable. And then you need a data scientist to look at that and analyze it using statistics to say, what does this mean? And then use that to inform clinical data. And so you do have to have a robust back end, specialty skills that can look at the data and use it. And so But I will say from, the organizational level and from the clinical level, like we collect so much data, like it is so much data. And I think some of the frustrations that we have is like, well, what are we going to do with it? We present on it, we talk about it, we use it to advocate, which is great. And coming back to the advocacy, we do send a lot of information to Vital and saying, how are we collaborating with the state? Sometimes we see data pop up and go, oh, that's an interesting story. Like it would have been nice to be consulted around that. And so there are some tensions around the governance of saying like, how will this be used? Where does it go? We're talking about data privacy for Vermonters, which is really important topic, especially if you're bringing it all together in one place. And so how do we protect privacy? But when we really look at it is like, how are we using the data that we utilize? And so one thing, I think bringing it all together to make it more efficient and make better clinical decisions is the point, but we collect so much data. How do you put that in a place where it's usable? And sometimes I just worry that the amount of data we collect is about compliance and about minimizing waste, but in our effort to basically prove that we're using dollars well, we create waste in the system. And so there's some sort of irony and feedback in saying like, this is a good idea, but it has to be done well. And there are a lot of factors that weigh into making this effective, more affordable, more efficient, and ultimately better outcomes in trying to utilize the most expensive services less. So it is hard to just look at this in a vacuum and say, yeah, this is a good idea and we would support it and we want to integrate it. And what does the governance look like? How is the data going to be used? How is it distilled down to people who don't have degrees in statistics or can't run SQL programs in the background and pull data and manipulate it in Excel? Like those are the kind of collateral pieces that are going to make this successful. And I think it's just coming back to really reframe of saying like, so what? I appreciate that you brought that up. It's more affordable and more effective and we have better outcomes. Like that has to be at the heart of any policy change. And then realizing the impact, I think we heard from other people saying, how do we take this on the road? And so we do home and community-based services, but we've invested in tablets that are connected to the internet. So that's 5G. Because there's not a lot of wireless. And so how do you make sure you have access to that? We have EMRs. We've invested in augmented intelligence technology that can help formulate a note for therapists. You can dictate and then it will create a note. It turns out KPIs for evidence-based practices. So those are technology like we're investing in. They're an expense, but it's really about the efficiency for people doing the work. So the administrative part is quicker so they can focus on the client care. But these are kind of I would say, I don't know if unintended consequence is the right word, but those are the things that kind of pop out as saying we want to collect more data and analyze it better, but now we need more people who can analyze it and distill it. And then we need the technology to help collect the data so that we're not overburdening the clinical folks. So I think we're bought into making that happen and working really hard with our partners in our area. But these are some of the pressures that come from policies like this, where we're really trying to connect. And then we've heard from different people, if you're in different places technologically, which I would include the state in that. And so we upload data, we use data from the MSR that I think is over 40 years old. We're trying to transition away from that. That can't happen. So we're going to modify it for the next year to update that and use it. But so how are we ensuring anybody who's weighing in, like what are the technological minimum standards to make this function? So I think there's some sort of analysis that's invested in here, but there are a lot of moving parts that'll weigh on the success of this. And I do think a lot of organizations are moving in this direction. It's just how do we do it effectively together? And we really need that from AHS and the state to drive that.
Yeah, and I just add on to the MSR piece, the agencies submit the monthly service reports to the state. It's antiquated. We talked last year about one of the proposals was, just like pull the information from VHI. We'll be able to just pull it easily from VHI. And once you dig into that, it gets extremely complicated. What the agencies would have to do with the vendors are out on their, on being able to agree to any new initiatives. It just gets more and more complicated. And so that got put on hold. But so I think that in larger language, the intent is really good. It's just how it's then implemented and how long it takes and what needs to take place in order to do that. One of the things you were talking about before with de-identified and identified data, there are data use agreements. There are ways to get around that. But again, it's about, the agreeing to that first, then the governance piece of that, and really ensuring the privacy of Vermonters.
Any questions? Yes, Lori.
So I'm curious if you have any thoughts. Well, one, I think this language is changing, right? We're getting new language from.
Yeah, we're getting consensus
Okay.
language from multiple different.
So we'll have to see after that, but I'm curious, some of the things you mentioned, like, unintended consequences, I wrote down, like, and other people have said this, like being able to use this in someone's home for a home visit and connecting, like, do you have any language thoughts of some type of additional, number here to make sure that it's, and you don't have to answer right now, but I'll be curious if you have any thoughts on,
Yeah,
what
no,
we
we'd be
could
happy
add
to
get to that.
look that over for sure.
Yeah. Thanks.
Thanks, Laura.
Any other questions?
I'm not gonna ask my standard question because you kind of answered it already. Guess if I repeated it enough, you'll just.
We were prepared, yeah, we're coming.
Thank you so much. Thanks for coming in.
Coming up.
And we have, I sort of meant to take a break before Elsie Simone, but is everybody dying for a break? We could take a really short one. Okay, well, two more people. Let's just power through then. Okay. If you need to take your own personal break, go ahead and do that. Hi, Susan, how are you?
Hey there, good. How are you all?
Good. Just looking for your comments on section 10 of S126.
Yes. Thank you for the opportunity and thanks for allowing me to testify via Zoom. I will send my written comments shortly. So for the record, I'm Susan Ritson from Health First Independent Practice Association. And I'll just say that Rick Dooley is our data guru for our organization, and he's seeing patients right now. So if there are questions that I can't answer, I'll have to take them back to Rick. But I'll first level set and just say that we come at this a little bit, not in the level of depth that others do, because the way it works in our network is all of our practices use different EHRs. There may be a few duplicates, but they're all in different systems. And Health First as an organization does not have all of our practices data, unless it's, when we had our ACO, we did that. But right now we don't have any data, repository for our network practices. I will say that we do support the integration or use of multiple data sources and allowing practices and patients to access it. So I'll just say that right out. It's not without cost though, and we recommend that resources be included for practices for this work. For example, the initial implementation of an interface can cost a practice $15,000 or so, and then the yearly maintenance can range around $1,500 per year per interface. So there is cost there, and not every practice is really able to, they don't have the analytic capabilities, especially for the smaller solo practitioner. So having some support for that would be helpful too, as Emma mentioned. The other kind of great thing that we'd love to see happen is have the ability for practices to pull down data from this database so they can bring it into their EHRs so that they're able to, have their triggers and just EHR-wide data analytics consider all of that data. So there's that. This isn't in section 10, but I just wanted to be on the record and mention it because I've heard there's talk about doing one EHR for everybody. And I just want to say that we would not support that. I can go into why if you'd like, but or just include it in my written comments. So there's that.
I think Mara,
I think
there was
Mara has a
never any
question.
serious talk about that. That was, yeah, that's not an issue that's actually on the table.
Okay, good. That's what I thought, but I just thought I'd mention it. I will say that, I think this work is important, and and we support it, as I said. But I do think that I'd actually like the bill to include more support for primary care. I think that would be more impactful in terms of affordability and accessibility if we put more resources into primary care. I know you all know this. I think the bill could include language about payment mechanisms, like a hybrid fee-for-service capitated payment at sustainable levels. We're not really doing that right now. There could be language in there about spending targets for primary care. And like I said, I think that would be even more impactful than some of this work, though we do support this work.
You're talking about just in general on the whole bill, primary care. You're not speaking specifically to section 10.
Correct.
However, you bring up a very salient point, which is should section 10 be, should we prioritize primary care in an integrated system of care? And, the ability to be able to should we focus on primary care at first to ensure that they're receiving all the information on their patients throughout the system of care?
If the work is properly supported. But I will say, throughout our network, almost all of our folks, all of our practices do have an EHR, but we have a couple practices that don't even have an EHR. And if you think back, 20, 30 years, we had really high quality care, a lot lower expenses, but, now that all this technology is around, that does add to the cost of things. And obviously we're in a world where we're going to have this data, and we need to use the data in the most efficient and useful manner possible. But it's not necessarily a way to get better care, lower price care, in my opinion. So balancing that, if you prioritize primary care, getting access to the data, it is one more thing that they would have to figure out and, deal with, and there's expense related to that. If it's properly supported, it could be worth it.
Wouldn't that support the concept of a patient-centered medical?
So, yeah, I'm not sure what you mean.
Your primary care as your medical home. If this was centered, if integration of healthcare data was centered around primary care, wouldn't that support the concept of a patient-centered medical home where your primary care has access to all your clinical information from all resources where you might be, and they were better able to manage your care?
Certainly. Yes.
Any questions for Susan? Okay. Well, thanks for joining us.
Yeah, thank you.
Okay. Hi, Sarah. You want to come on up?
Good morning. Sarah Teach out with Blue Cross and Blue Shield of Vermont. And just so you know, I did include written testimony in the memo that I wrote on the entire bill. So this is at the very end of that, I think page 4. And I'm really focused on the integration of healthcare claims data with clinical data. So there's been a lot of discussion here about how you could better use clinical data and interoperability amongst clinical data, but actually the real meat of this section of the bill is C, the part that says health insurers, as defined in 9402 of this title, shall provide clinical and claims data to the Agency of Human Services as directed by the agency in order to facilitate the integrated system of clinical and claims data. So that's what this does. Just to be completely blunt. So just to be straight up, we oppose integrating commercial healthcare claims data and clinical records at this time. So we feel that there are a lot of other things that should happen first in the healthcare system. And I'll go through sort of what our concerns are. We have concerns about privacy and security. We have concerns about legal and governance issues. We have concerns about resource issues. We have concerns about, if I already said privacy, and then just practical concerns about how this kind of big database would work. So claims data is not immediate data that can be used in a clinical setting. So there's a considerable lag between when we receive the data, the bill essentially from the provider, adjudicate the bill, and then have the data that's actually ready to be used in this VCures. Right now, we send it to VCures at the Green Mountain Care Board. I'd say 6 to 9 month lag, easy on the data. So that makes it not usable in real time to improve clinical care, which I think is some of the focus of this committee. And it's pretty limited information in the claims data. This is about billing. So it's the codes that they're billing us. And we actually add the pieces about how much it costs with each of the different providers. And I think the other piece would be how much the patient owes versus how much their provider pays. All of that information is available other places. So there's nothing miraculous about the claims data that's going to get you that information. So we really appreciate all the efforts here to make real-time clinical decision-making better. But this is a research tool, and we think that the research pieces have a long way to go before they're really useful. So just to jump into some of the reasons. So our data is not complete. The data we currently submit to VCures. Any self-funded employer, so all the ERISA groups, except for State of Vermont and VHI, who are mandated to submit their data, can choose whether or not they want to submit data to the state as part of this database. And I will tell you that almost all of them have chosen not to. And the real move away from submitting data was 2 years ago when the legislature approved individually identifying the data in the database. That's when we lost almost all of the private employers. So there was a lot of concern about what that would do. So the data is pretty incomplete. And I think you heard that when Oliver Wyman used the VCures data to make their Act 167 report. There were a lot of complaints about this was an incomplete data set. It didn't have all the information. It's because that's the data that's being used. So you're asking to integrate an incomplete data set and try and do some pretty significant analysis on it. We don't believe that's worth the time, the money, the resources that it takes to do this. We also know that Medicare claims can't be integrated. So it's only going to be commercial claims and Medicaid. So it's about 1/3 of the population. Claims data won't be in this database. A couple of the, the privacy issues and the governance issues are a little bit intermingled, but we know that, for example, the privacy issues around abortion data, gender affirming care data, some of that data is different for claims data than it currently is for clinical data, and how those different governance pieces are aligned is of particular importance to us, and we think that that would need to be worked out and resolved first. So they also treat mental health and substance use data differently. And right now, clinical data and claims data, we're required to do different things with the data. There's also a number of, I don't need to explain to you what the privacy issues are, but creating one massive database of all of Vermonters' clinical and claims data makes it a target for anyone who wants to get into that database. I'm sure that everyone is trying their best to keep the data secure. We do as well, but there have been a lot of breaches of data And this just, currently the data is housed in separate places, and this would put it all in one place and make it a even bigger target for a data breach. I would also note that in our data privacy bills, government is generally excluded from all the requirements. So you just need to think about the policies you're implementing across all different sections of this. And then I think the last couple things are resource issues. So we estimate it currently costs Blue Cross and Blue Shield of Vermont about $500,000 a year to submit our data to VCures. This is going to create an entire secondary data submission requirement to AHS. It doesn't say anywhere in here that the data has to be aligned, that it has to be the same data. So AHS could have all different data parameters and be requesting all different things from us. So I don't want to say it could be double the cost, but it's possible with the way you currently have it. There's no efficiencies contemplated here in the data access. And it takes quite a bit of our staff's time to keep up to date with the different requests. The data changes, the different data fields change, what VCures is requesting of us every year. There's a pretty substantial report that goes through every data change that they want, and we have to line it up with our internal data fields so that we're submitting what's being asked for. It's not a static decision. It's not, we just want these data fields. It's constantly changing. And a lot of the information, I hear a lot of ideas that this will give information about payment information. It certainly will, down to the individual patient level, how much each individual patient is paying. But there's a lot of information already out there on the prices that are being charged for services that can be compared across. I'm not sure you need to know exactly what each individual Vermonter is paying for their services to do that type of analysis. So those are I think the high level concerns. We just think there's so many multiple and serious data limitations that we really believe that this project at this point does not have the value to improve our healthcare system, to make it worth the resources that would be required to invest in this.
Thank you. And can I ask right now, would you be willing to come back once we receive some other language from other people? Would you like to comment on that?
Yes, I haven't been part of the group that's coming up with a compromise, so I don't know what they're proposing. So
Okay.
I'd like to come back.
Yeah, that would be great.
When you're considering that.
Yes.
Thank you.
We'd like your feedback on that. Any questions for Sarah? Okay. Thank you. Well, glad we powered through. Looks like we're done for the morning, so we can go off of live.